Hi friends, welcome back to a new class. Today we are going to discuss about neurotic stress related and somatoform disorders. According to ICD-10, there are three important types of neurotic stress related and somatoform disorders which include phobic anxiety disorder, other anxiety disorders and obsessive compulsive disorders. First we will discuss about anxiety disorder. Anxiety is a normal phenomena. It is characterized by a state of apprehension or unease arising out of anticipation of danger. So anxiety, anticipation of danger. We are expecting some danger to happen which causes some uneasiness in our mind, that is called anxiety. So anticipation of danger, very important. Anxiety is anticipation of danger and an unease arising out of anticipation of danger. Whereas fear, it is an apprehension in response to a external danger. So there is a real external danger existing in case of fear, whereas in anxiety there is no real external danger. We are anticipating some danger to happen. So while anxiety, the danger is largely unknown or internal. So that's the difference between anxiety and fear. In anxiety, there is no real external danger. We are anticipating some danger to happen, whereas in case of fear, there is a real external danger, so that some uneasiness happens in the mind. Normal anxiety becomes pathological when it causes significant distress and or impairment in the functioning of an individual. So when it causes significant problem to the individual, then only it is a pathological one. Otherwise, anxiety is a normal phenomena. There are two types of anxiety in general, that is trait anxiety and state anxiety. What is trait anxiety? It is the habit of or habitual tendency to be anxious. Some people will have a trait that they are anxious always. That is called a trait anxiety. For example, I often feel anxious. The person says that I often feel anxious. So always and always the person have some or other kind of anxiety. That is called trait anxiety. Second one is state anxiety. This is the anxiety felt at the present or the cross-sectional moment. I feel anxious now. So because of some particular state of time, the person will have anxiety. For example, at the time of examination or at the time of a stage performance. Likewise, a particular state can induce anxiety. That is called a state anxiety. So two types, trait anxiety, state anxiety. Now we pass on to the pathological anxiety, that is generalized anxiety disorder. What is generalized anxiety disorder? It is characterized by an insidious onset in the third decade. It's a stable one and it runs a chronic course. And symptoms of anxiety should be there for at least 6 months for diagnosing it as generalized anxiety disorder. It is the commonest psychiatric disorder in the population. So anxiety disorder is the commonest psychiatric disorder in the population. Why? Because most of the psychiatric disorders will have associated anxiety, and the person may be presented to you as a case of anxiety disorder sometimes. Next is panic disorder. It's another case of anxiety disorder. It is characterized by discrete episodes of acute anxiety. Acute and overflowing type of anxiety is called panic disorder. It is of sudden onset and lasts for a few minutes, and it is characterized by very severe anxiety, and it is 2 to 3 times more often in females. The treatment of anxiety disorders, usually it is multimodal. No single treatment is sufficient. It's a multimodal treatment. It includes psychotherapy, relaxation techniques, behavior therapies and drug treatment. The drug of choice for generalized anxiety disorder, very important, it is benzodiazepines. And for panic disorder, it is antidepressants. And for both, we will give beta blockers as adjuvant. And for anticipatory anxiety, for example, for some people will have an anxiety during severe anxiety during their exams, their practical examinations or their stage performance and all. At that time, in order to prevent the anxiety, we can administer beta blockers like propranolol and atenolol. That is called anticipatory anxiety. So beta blockers are the drug of choice for anticipatory anxiety. Next is phobic disorder, very common question in this multiple choice examinations and all. So listen very carefully. Phobia is defined as irrational fear of a specific object, situation or activity. So it's an irrational fear of object, situation or activity, often leading to persistent avoidance of the feared objects and or situation or activity. So whatever is the feared stimulus, the person try to avoid, and the peculiarity is that it's an irrational fear. So very important, it's an irrational fear. So the common types of phobia are, first one is agoraphobia, second one is social phobia, and the third one is specific or symbol phobia. Then what is agoraphobia? It's an irrational fear of situations. It is the commonest type of phobia encountered in clinical practice. It is characterized by an irrational fear of being in places away from the familiar setting of home. It includes fear of open spaces. In multiple choice examinations and all, this will be the option. Fear of open spaces is called. Usually, it is one of the types of agoraphobia. Anyway, don't confuse. Fear of open spaces can be called as agoraphobia. And also in fear of public places, crowded places, or any other place from where there is no easy escape to a safe place is possible. So the person believes that I am totally trapped, I can't escape from here. So likewise, such a feeling of situations is called agoraphobia. Fear of open spaces, you can call it in general. Next is social phobia. This is an example of irrational fear of activities of social interaction. So whenever there is a social interaction comes, the person is having very acute fear of that situation. It is characterized by irrational fear of performing activities in the presence of other people or interacting with other people. So that is called social phobia. Social means interaction, social interaction. So fear of social interaction. Next is specific or symbol phobia. It's specific or symbol phobia. The stimulus is usually well circumscribed. So it's specific or pointed objects or situation will be the cause of fear. This is an example of irrational fear of objects or situations. So these are the ones which are commonly asked as options and all. So you can see acrophobia, that is fear of high places. Acro means high, acrobatics you might have heard. Acro means something related to height. So acrophobia, fear of high places. Zoophobia, fear of animals. Xenophobia, fear of strangers. Algophobia, fear of pain. Claustrophobia, fear of closed places. There are n number of phobias, and these are the common phobias which may be asked for your exams and all. So keep in mind these terminologies. Next is regarding the treatment of phobia. Here also the treatment is multimodal. Include psychotherapy, behavior therapy. In behavior therapy, the techniques used are flooding, systematic desensitization, exposure and response prevention, relaxation techniques and all. So all these are discussed in the therapy session under behavior therapy. For details, you can watch those videos. Then regarding the drug treatment, the benzodiazepines are the drug of choice. Among that, alprazolam is the commonly used drug for these disorders. And antidepressants like SSRI, for example, paroxetine is the commonest SSRI, and fluoxetine, sertraline, imipramine, and phenelzine. These are monoamine oxidase inhibitors. All these will be discussed in the psychopharmacology sessions. So these are the common drugs. You just don't forget about benzodiazepines or alprazolam. That's the commonest drug which is given. Next is obsessive compulsive disorder. Very important. Another very important topic. What is an obsession? An obsession is defined as an idea, impulse or image which intrudes into the conscious awareness repeatedly. So into the mind of the person, some idea, impulse or image is consistently coming with even with resistance. The person cannot block that thought. It will coming without our permission, even with our resistance, and it is very distressing for that person. That is called obsession. It is recognized as irrational and absurd by the person, so that insight is present, insight is preserved in OCD, and the patient tries to resist it against but is unable to resist that, and failure to resist leads to marked distress in that individual. Next is compulsion. What is compulsion? It is a form of behavior which usually follows obsessions. It is aimed at either preventing or neutralizing the distress or fear arising out of obsession. The behavior is not realistic and is either irrational or excessive. Insight is present so that patient realizes it as irrational and it's the irrationality of compulsion. The behavior is performed with a sense of subjective convulsion. So the person has a subjective compulsion to perform the act in order to relieve the anxiety out of the obsession. So the sequence is that obsession creates significant anxiety within that individual. So somehow the individual have to get rid of that anxiety. He performs some act that is called compulsion to get rid of that anxiety so that the anxiety is relieved. So that is the sequence of obsessive compulsive disorder. The compulsions may diminish the anxiety associated with obsession. So that is obsession and compulsion. There are 4 clinical syndromes in OCD. Obsessive compulsive disorder is manifested as mainly 4 clinical syndromes. First one is washers. This is the commonest type. Here the obsession of the is of the contamination with dirt. The person believes that he is contaminated with dirt. His hands are contaminated with dirt or germs or body secretions, and he always go to wash and clean his hands. The person tries to avoid contamination, but he is unable to. So washing becomes ritual. So cleaning is obsessed with cleaning, and this is called washers. Next is checkers. In this type, the person has multiple doubts. Example, the door has not been locked, kitchen gas has been left open, counting of money was not exact. Likewise, the compulsion is checking repeatedly to remove the doubt, and any attempt to stop the checking leads to mounting of anxiety. You cannot stop that person. If you are stopping that person, he will have severe episode of anxiety. Before one doubt has been cleared, other doubts may creep in. That's the problem. If we have cleared one doubt, it will not stop there. It will result in another doubt, and the person will go and start clearing that doubt, and ultimately resulting in poor performance then social and occupational life. That's the problem. Next is pure obsessions. This syndrome is characterized by repetitive intrusive thoughts, impulses or images which are not associated with compulsive act. Here only obsessions are there, no compulsion. That is called pure obsessions. The content is usually sexual or aggressive in nature. That's why the person cannot, and the person is having insight, so he cannot do this sexual or aggressive nature kind of compulsions. So he is not going to do anything, but the anxiety prevails. That is pure obsessions. Then primary obsessive slowness. It's a relatively rare syndrome, and it is characterized by severe obsessive idea and or extensive compulsive rituals in the relative absence of manifested anxiety. So there is obsessive idea followed by compulsive rituals, but there is no manifested anxiety because it has become a ritual, and the anxiety is usually relieved because of the obsession. So it comes as one followed by another. This leads to marked slowness in the daily activities. So the person's daily activities are markedly slowed. That is called primary obsessive slowness. Next is the treatment of OCD. The treatment mainly aims at psychotherapy. Under that, psychoanalytic psychotherapy, supportive psychotherapy, behavior therapy, and cognitive behavior therapy. In the cognitive behavior therapy, the techniques used as thought stopping. So this is a problem with the irrational thought. So thought stopping methods are taught. Then response prevention. The person's compulsive acts are prevented. Then systematic desensitization. Then modeling. All these are the techniques used. The drug treatment include benzodiazepines, example alprazolam and clonazepam. Then antidepressants like clomipramine, fluoxetine, fluoxamine. Then antipsychotics in low doses in case of severe distressing anxiety like haloperidol, risperidone, olanzapine, aripiprazole, fumoxide, etc. And also buspirone is another drug of choice. Then ECT is given in presence of severe depression with obsessive compulsive disorder, and also in case of this intractable OCD. Next is dissociative and conversion disorder. So these are another type of classification of these neurotic disorders, neurotic and dissociative and conversion disorders. So dissociative disorder and conversion disorder are the new topics which we are going to discuss now. What is conversion disorder? The clinical features include presence of symptoms or deficits affecting motor or sensory function, suggesting a medical or neurological disorder. And there is sudden onset, development of symptoms usually in the presence of a significant psychosocial stressor, a clear temporal relationship between stressor and the development of and exacerbation of symptoms. When patient does not intentionally produce the symptoms, there is usually a secondary gain out of these symptoms, and detailed physical examination and investigation do not reveal any abnormality. The symptoms may have a symbolic relationship with the stressor or conflict. So what happens? There is a significant psychosocial stressor or conflict with that individual. For example, if an individual has severe tension related to the exam, so this stress, he cannot bear this stress, and this stress is converted into some physical symptoms. For example, his right hand is paralyzed, so that he cannot write the exam. So the stress is relieved. So that is the peculiarity of conversion disorder. That is, it is converted into, the stressor is converted into some physical symptoms. The types of dissociative conversion conversion disorders include dissociative motor disorder. That's the movement is affected, such paralysis, for example. Then dissociative sensory loss, for example, glove and stocking anesthesia. That means the area which wearing the glove, that's the palm area, having sensory loss. That means, and also stocking area is having sensory loss. Usually the neurodermal pattern, it does not follow such a pattern of paralysis, so that we can easily identify it as something related to psychiatric problem, that is conversion disorder. Then next is dissociative convulsion, that is hysterical fits. The commonest name is hysterical fits. So these are the main three types of conversion disorder. Next we discuss about the dissociative disorder. The clinical features include similar one, disturbance in the normally integrated functions of consciousness, identity and memory is impaired here. And onset is usually sudden and the disturbance is usually temporary. Often there is a precipitating stress before the onset. There is clear temporal relationship between the stressor and the onset of the illness, and also secondary gain resulting from the development of symptoms may be found. Detailed physical examination and investigations do not reveal any abnormality, and this is the peculiarity. Here the types include, you can see first one, dissociative amnesia. So because of the psychosocial stressor, the person forgets about that this psychosocial stressor episode. Stress episode is completely forgotten. That is called dissociative amnesia. Then dissociative fugue. If the person has severe stress, he runs away from that place and he assumes a new identity and lives as a new person in a new place. That is called a dissociative fugue. Then dissociative identity disorder means because of the stressor, the person's personality get dissociated and he assumes multiple type of personality. It's otherwise called multiple personality disorder. You may be remembering the film Onion. So in that, the severe stress causing that person to dissociate into several personalities. That is called dissociative identity disorder. Next is trance and possession disorder. That means the person will have possessed with some kind of spirit or some kind of deity. So that kind of behavior is called trance and possession disorder. This is the psychopathology of happening in conversion disorder and dissociative disorder. How does it happen? So we can see whenever there is a stress happens in a person, the first line, the primary defense mechanism hacked upon. So the primary defense mechanism usually resolves in normal cases. If it is not possible to resolve the stress, it is not fully successful, what happens? The secondary defense mechanisms act upon. It can either be a dissociation or dissociation and a conversion. If it is dissociation, a part of the personality is dissociated from the rest and the person will have amnesia, dissociative identity disorder or trance and possession disorders. And if it is conversion, what happens? The conflict is converted into some somatic symptoms with a symbolic representation, paralysis, anesthesia, likewise, and it will be manifested as conversion disorder. So this is the psychopathology of dissociative and conversion disorder. The secondary defense mechanism is the one which predominates here. Then regarding the treatment, behavior therapy, psychotherapy with abreaction. What is abreaction? Abreaction is bringing into the conscious awareness thoughts, affects, and memories for the first time. So the person will have some stressful memories, stressful thoughts or affects, whatever it may be. When it is brought out to the conscious awareness, the symptoms may be relieved most of the time. And this process is called abreaction. So this can be achieved. The abreaction can be achieved by the following ways. First one is hypnosis. You can give hypnosis, hypnotherapy, so that the person will bring it out. Then free associations. That's a technique of psychoanalytic psychotherapy, that person will be asked to talk freely, and by talking continuously, his subconscious stresses will come out. Then intravenous thiopentone or diazepam. These are narcotic drugs which will be given so that the barrier is broken and the person can bring out the stressors. So these are the techniques by which abreaction is carried out. Then regarding the drug therapy, drug treatment has very limited role in case of dissociative and conversion disorders. Next is somatoform disorders. It is characterized by repeated presentation with physical symptoms which do not have any adequate physical basis. A persistent request for investigations and treatment despite repeated assurance by the treating doctors. The somatoform disorders are divided into, first one, somatization disorder. In this, the multiple somatic symptoms in the absence of any physical disorder. The symptoms are recurrent and chronic. At least 2 years duration is needed for the diagnosis. The symptoms are vague, presented in a dramatic manner, and involve multiple organ systems. There is a frequent change of treating physicians and persistent refusal to accept the advice or reassurance. The treatment is supportive psychotherapy, behavior modification, relaxation therapy, drug therapy like antidepressants and or benzodiazepines. Next is hypochondriasis or hypochondriacal disorder. It's another common question which may be asked in multiple choice examinations. It's defined as a persistent preoccupation with a fear or belief of having one or more serious diseases based on person's own interpretation of normal body function or minor physical abnormality. So the normal bodily problems or bodily manifestations will be taken as abnormal and manifestations of a serious disease, and the person believes that he has some serious end stage diseases which will take his life. And even if we are giving clear-cut rationale, there is no disease, he doesn't believe that. So that's all about the neurotic, stress-related and somatoform disorders. All the topics which I have discussed here are very, very important in case of any kind of examinations. So kindly study well and do the questions related to these topics. I will be updating the questions related to the already completed classes in mental health nursing and all other subjects. So follow those videos, and also you can do your question banks or your rank files and do maximum number of questions so that you will be able to tackle the questions very easily. Once again, there is no shortcut to success. It is hard work only. So work hard for a better tomorrow. Thank you, and all the best.